Now that we've talked about some of the ethical concerns that apply to all of these genetic tests and some laws that are currently in place to protect that genetic information, let's focus individually on the types of genetic testing that's done today. The first we will focus on is diagnostic testing, which is defined as a genetic test to establish or confirm a medical diagnosis. A common theme as we've been moving through these units is the improvement of DNA sequencing technologies. And with that, our increased ability to sequence DNA, our genetic discoveries have very much increased. And so too has the production of our genetic tests. In fact, there are currently about 75,000 different genetic tests, with about 10 new tests added per day. You can see from the timeline over to the right that we have a number of new genetic tests hitting the market every single day, and this number is climbing significantly. And these specific genetic diagnostic tests test for a number of disorders across the medical spectrum. An example of diagnostic testing is prenatal or newborn screening, which is when a newborn is tested for a group of health disorders. Interestingly, newborn screening decisions, including what disorders to test for, are state-run. So in effect, we have 50 separate genetic screening programs. This also includes financing of those genetic tests, consent, educational information provided, and any follow-up procedures that are recommended. You can see the differences in newborn screening across the nation in the figure to the right. Specifically, in Pennsylvania, newborn screening is required by law. However, many states, including Pennsylvania, allow parents to refuse newborn screening for religious or other purposes. Despite these separate screening protocols, all states must screen for at least 21 disorders by law. Currently, tests are limited to conditions for which childhood medical intervention is possible and may be beneficial if the disorder is detected early. In an attempt to alleviate some variation across state lines, ACMG created a Recommended Uniform Screening Panel, or RUSP, which is a list of 35 core conditions and 26 secondary conditions. Importantly, the RUSP is simply recommendations at this point and not national law, but it serves as a helpful guide for the states. After consulting the RUSP, each state then chooses which conditions it will include in their newborn screening program. Another type of genetic testing that is becoming more popular is carrier screening. Carrier screening, or carrier testing, is screening adults to determine if they carry specific mutations where the risk of having a child with a genetic defect or disorder can be calculated. This is becoming increasingly popular as genetic counseling, or when a health professional seeks to help a couple make informed reproductive decisions based on their underlying genetics. The classic example is in the case of what's called a recessive disorder. Or in other words, the affected child needs to have 2 copies of the bad version or bad allele of a gene to show symptoms and actually have the disorder. We can see that if both parents are carriers of this particular recessive disorder, or have 1 bad allele and 1 good allele, they have a roughly 50% chance of passing the bad allele or bad version of the gene to their children. You can see how we can quickly get an idea of the probability of having a child affected with the recessive disorder. In this particular example, about 25%. They also have a 25% of producing a child that does not carry any version of the bad gene, and a roughly 50% chance of producing a carrier, or someone that has 1 bad version of the gene and 1 good version. We can see the pros and cons listed here for us. The benefit of these particular genetic tests being that this type of testing can allow us to make informed reproductive choices. However, there are several cons, mostly related to having a full understanding of what it means to be a carrier of a genetic disease. Let's focus on an example with sickle cell anemia and how that led to widespread discrimination because of an incomplete understanding of the carrier state. Sickle cell anemia is an inherited recessive blood disorder. Remember that recessive, in other words, means you need 2 copies of the bad version of the particular gene to actually show symptoms and have the disease. Among other severe medical complications, the patient's expected lifespan is less than 50 years. It affects close to 100,000 people in the US and millions of people worldwide. Now, in the early 1970s, then President Nixon proposed a national health strategy that included research funding toward the treatment and understanding of sickle cell disease. Shortly thereafter, carrier screening for sickle cell anemia was instituted. In a short amount of time, several states passed laws mandating sickle cell genetic testing. This was specifically targeted at African Americans, and this was because African Americans suffer from this disease by a higher proportion than many other populations. This led to a widespread stigma of even the carrier state of the particular disease. This was based on a misunderstanding of what the carrier state actually was. Because the test and results were not accompanied by widespread education, the results of the carrier state, remember carrier in this case only meant that they have one bad version of the gene, but didn't actually have the disorder, African Americans were denied educational opportunities, jobs, and even insurance simply because they were carriers of the trait. This early history of sickle cell screening and false diagnosis illustrates the complexity of the social and ethical questions surrounding genetic testing. The next set of genetic testing that brings up its own ethical issues is this idea of predictive genetic testing. This type of testing is to determine if a currently asymptomatic individual or person that isn't showing any symptoms of a disorder will become affected with a genetic disease in the future. Now, a great example of a predictive genetic test is the one performed for Huntington's disease. Huntington's disease is a neurological degenerative disorder that has an onset between ages of 30 and 50 years old. This is what's called a dominant inherited condition. So as opposed to the recessive disorder like sickle cell disease that we were talking about previously, this one only requires one bad version of the gene to begin showing symptoms between the ages of 30 and 50. What makes predictive testing so interesting from an ethical perspective, and especially is the case with Huntington's disease, is that this particular disorder has no cure and it is progressive. And what that means is that over time it becomes worse and worse. In fact, in this specific type of disorder, only about 15% of individuals that are asymptomatic, again, not showing any symptoms, with an affected parent, choose to have the test. And so by and large, even if they have a chance of developing those symptoms later in life, they don't choose to have this specific predictive test. So this brings up a lot of interesting ethical questions. Would you want to know this type of information? Even if you did have an affected parent, they have a 50% chance of passing that along to you. Do you want to know if you're going to develop symptoms later in life? Do your employers have the right to this information? If you are between the age of 30 and 50 and obviously working age, should your employers have the right to know? Who owns the information from this particular genetic test? How would this information impact your reproductive choices, having children and so forth? Should family members be privy to these results? And obviously, the emotional impact on family members and potential for discrimination are ethical considerations as well. The last type of genetic testing we'll discuss today is the direct-to-consumer genetic tests. These types of tests are ancestry or health-based genetic tests with reports that are given directly to the consumer. These are done through specific companies like Ancestry.com or 23andMe. These have been growing in popularity because not only are they cheap, they can also be done very quickly, and they can tell us a lot about our ancestral backgrounds. The benefits of these tests include they can help you be more proactive about health. There's no specific approval required as far as medical approval. They're very inexpensive. Sample collection is non-invasive, usually involving the collection of a saliva sample, and the results in a large population can be used to further genetic research. Obviously, there are drawbacks and concerns with this type of genetic test, including you might possibly get unexpected information, and this information can be upsetting. There's little to no oversight with these genetic tests and how the information is delivered to individuals that get the test. The information from these tests can also be used to make important medical decisions on misleading information. Because there's little to no oversight, this also raises genetic privacy concerns. Where does this data go? Where is it stored? Who owns this data? And along with that, who can use this data and to what end? And then finally, a question that's raised some ethical concerns over these direct-to-consumer genetic tests. Should these tests be allowed to return medical information about genetic variants that are specifically found? That is, if the genetic test uncovers that you have a specific variant that makes it very likely that you'll develop a particular disorder, should this type of information be returned to you, or should it not?